There is a change in the topic. Actually, I spoke to Dr. Srinivas, who is the organizer, because there is the same
Okay,
present role of low-mark happens is being discussed in another room there at a
okay.
different
Yeah,
place.
please go ahead.
So this is going to be a NOACs and CAD, and we all
Okay,
know low-mark happen role in the CAD is not new. It's been known since almost like 2 decades. So we don't have to speak in this important session. So I'll be brief. Time that's allotted to me is about 10 minutes. I think I'll respect the time. So the present role of NOACs and CAD, if you look at why we are actually trying to look at this role of NOACs in the CAD is that we know from the REACH registry, when we follow the patients with risk factors only or people who got so-called stable, now we call it chronic atherosclerotic disease, prior ischemic event of more than 1 year or prior ischemic event less than 1 year, you see the events are actually progressively increased when you're trying to see the patients with these kind of backgrounds. So there is a progressive increase in the events depending upon the background of their risk. The 3-point MACE tends to be uh, almost higher than the 4 years in these people. So from the series, from so-called what you call a stable coronary disease, we still see these patients actually having CV death, MI, and stroke almost over 4 years in 12.2% of the patients. So this led to what we call a kind of adaptation of certain of vascular protection therapeutics in the form of pillars in the lipid lowering, blood pressure control, blood glucose control, and thrombotic protection with aspirin and DAPT. But is there a scope of improvement with the current antithrombotic regimens? That's what we are trying to see, whether we can additional protection. We have real antiplatelet therapies, which have been almost like going up from the last 1.5 decade to 2 decades. The Capri trial and with clopidogrel or Charisma trial with clopidogrel aspirin, then came the Pegasus 90 milligrams of ticagrelor as aspirin versus ticagrelor 60 milligrams aspirin and Themis in diabetic population. All have showed, although there was a trend towards a decrease in the MACE with when adaptation of DAPT, but one thing is common with all these studies is they have increased that TIMI major or Gusta major bleeding, but it did not decrease any kind of CV death in this kind of trials. No decrease in the death, and sometimes some of these trials, even the MICE which was decreased was also not statistically significant, and especially in Charisma. Now, the residual risk remains despite guideline recommended therapy with AS inhibitor or PT2 receptor blockers, statins, and of course with beta blockers or ACE, ARB, all combined together. Well, still you'll find almost 15% CV deaths, MI, and stroke in this population over a period of 4 years. Now, to address this issue, with anticoagulation was added to the aspirin in way back almost like 3 decades back with various trial showed, although there was events were decreased in terms of MACE, but definitely the major bleeding was a problem, unacceptably high bleeding rate that was seen in combination with aspirin offering. Then came the NOACs, the Atixban trial, APRISE trial, which was actually prematurely discontinued because of the fact there was an unacceptably high bleeding rate. So it didn't work at all. Then came a REDEEM trial with dabigatran. This was a trial which was actually seen the possibility of giving NOAC in setting of acute coronary syndrome, which showed that a progressive increasing in bleeding tendency with a progressive increased doses of dabigatran right to 50 milligrams to 110 milligrams. So this also led to an increased bleeding, and that it was not acceptable for the patients to be given acute coronary syndromes. Then came the ATLAS trial. The ATLAS trial is a wonderfully conducted trial where the one of the NOAC, the Rovax1, ultra low levels of the dose, 2.5 milligrams and also 5 milligrams, were tested against a placebo in the background of aspirin or a dual antiplatelet therapy. And the results were quite astonishing. In fact, at the end of 24 months, they showed that statistically significant decrease in the MACE of 16% decrease in the MACE and about 32% decrease in the cardiovascular death and all-cause mortality as well. Not only that, in those patients who underwent stenting, there was a definite decrease in the stent thrombosis, which was significant by 31% decrease. But the problem was that there was an increased bleeding in those patients who are taking roxaban along with aspirin or dual antiplatelet agents. However, lateral bleeding and was not increased in low-dose rivaroxaban 2.5 milligrams, and neither there was a statistically significant increase in fatal bleeding. So, with this background, with of course the rivaroxaban being used as an additive agent to antiplatelet agent in acute setting, that is ACS patients, the COMPASS was also planned, which is a trial which was done in those patients who are chronic CAD and PAD. And then the population involved was a large population, 27,000 patients. And this was almost followed about 23 months, and it was terminated early because of the statistically significant improvement in the active drug group. Roxban has shown that there is a 24% relative risk reduction in the patients as far as the MACE is concerned when it is compared to placebo, and almost like 22% reduction in CV death, MI, stroke also decreased non-significantly. But all-cause mortality was also shown to be reduced significantly. Even stroke rates were also significantly reduced with the rivaroxaban. Major bleeding, of course, was increased, but not the fatal bleeding. Neither intracranial bleeding was increased in these patients. So this was a eye-opener to the fact that a new vertical pillar in the setting of chronic ischemic heart disease, trying to protect the patients from major adverse cardiovascular events, especially the limb events when they are actually associated with peripheral vascular disease as well. Then, out of these patients which are involved in this trial, there are a subset of population which are actually received a major advantage of using this dual pathway inhibition, that antiplatelet inhibition, and as well as the thrombotic generation pathway. Patients who had two vascular beds which are involved in the cerebral, in addition to coronary or coronary plus peripheral vascular disease, as limb disease, had the highest benefit of having the benefit of prevention of MACE and also limb events when rivaroxaban added to aspirin therapy, 2.5 milligrams, of course. And the next in order was the history of heart failure. And third in order was patients who had renal dysfunction, whose GFR was less than 60 ml per minute. And of course, the diabetic population also received a additional benefit compared to the general population. So these are the kind of high-risk population in those patients who actually have a background of vascular disease in the form of coronary disease or peripheral vascular disease, who received immense benefit with dual pathway inhibition. Now, in comparison to the earlier trials of dual antiplatelet therapies, the Charisma, Pegasus, and also the Themis, COMPASS trial shows evidence of MACE being reduced statistically significantly by 24%, CV death by 22%, stroke by 42%, and at the same time, the amount of bleeding that they have received in this active group was much less than what you have seen in Pegasus or Themis trials, which was a 160% increase in major bleeding in TIMI major bleeding and 132% TIMI major bleeding in Pegasus 60 milligrams with aspirin group. Compared to that, it is about modified ICTS bleeding in this group showed about 70% increase. Of course, there is a major bleeding was increased in the active group, but no increase in intracerebral bleeding nor a fatal bleeding in those patients who had dual pathway inhibition. So with this, if you compare the COMPASS contest with aspirin, lipid-lowering therapy, BP-lowering therapy, and ACE inhibitors, if you look at the MACE in comparison, all these trials, like aspirin, it was actually added in 3 decades ago for vascular protection, showed a 19% reduction in the MACE, and we have COMPASS, rivaroxaban, when aspirin added, 24% reduction in the MACE is seen. A significant decrease in the death and stroke is also seen, and also the major adverse limb events also decrease in those patients who had peripheral vascular disease when aspirin was added to rivaroxaban when added to aspirin. So this shows importance of a dual pathway inhibition in those patients who got a chronic ischemic heart disease, especially in those patients who got high risk background. Thank you very much.